So welcome to everyone, and we are going to continue our discussion on ischemic heart disease. The other day we have seen the T waves and the angina, the what is injury, what is ischemia, and what is infarction. We also learned a bit about different types of angina and the changes in T waves. Now we are going to get into the acute coronary syndromes, which are the bread and butter of any cardiologist. Acute coronary syndrome. All other diseases put together, they constitute around 20%, 25% of practice in cardiology. And acute coronary syndromes and coronary artery disease itself occupies around 60-70% of the practice. In physicians also, in your practice, you are going to definitely get a lot of cardiological cases of acute coronary syndrome as well as coronary artery disease. It's imperative for us to learn the in and outs of this particular disease. So let's go ahead and then look at, I'll share my screen. So, welcome. And of course, again, we're going to use a lot of clinical input into the understanding of ECG. I'm not making it a dry ECG reading session for all of you, as you are aware that we are going to discuss every time the clinical correlation between what we are doing and what we are seeing in the ECG. We are doing that. And let us see that. Acute coronary syndromes. This is not one disease, a bunch of diseases which have interrelated pathogenesis and progression, and they are grouped under one heading called acute coronary syndromes. So just understand there are two types of plaques, a vulnerable plaque and a non-vulnerable plaque. What is a plaque? A plaque is a deposit of LDL and associated debris under the endothelium in the blood vessel. If it occurs in the coronary blood vessels, it can result in coronary occlusion. So a non-vulnerable atherosclerotic plaque is where the cap is very firm and is rich in fibrin, and then very little LDL quantity is less, cellularity is more. Such a plaque is called the non-vulnerable plaque. What happens is sometimes the vulnerable plaque, the cap of the plaque gets opened up due to various reasons, and that becomes a vulnerable atherosclerotic plaque. And this is very thin. The fibrous cap, fibrin cap is very thin, and the LDL is very rich here, oxidized LDL. This all is under the endothelium. So if the plaque opens up and the lipid-rich and inflammatory kinds rich, chemical-rich material is exposed to the blood, and that is the dent there, plaque minor disruption, and that incites what is called thrombosis because of the vasoactive substances and the chemotactic cells. That results in non-occlusive thrombus. So this is a non-occlusive thrombus. The blood flow can still go and it is not totally occluded. This non-occlusive thrombus may be asymptomatic depending on the amount of blood flow, may be unstable angina, or maybe an STMI or non-QA myocardial infarction. So where ST segment is depressed, only subendocardial ischemia is felt and there is no transmural effect. Supposing the block is complete with the associated thrombus formation and an occlusive thrombus, there is the patency of the blood vessel supply to the distal part of the myocardium is jeopardized, and immediately there will be an acute cardiac event which is called acute myocardial infarction, or sudden cardiac death can occur. This is also QA myocardial infarction or ST segment elevation myocardial infarction. So a non-vulnerable plaque, they go on exchanging between themselves. Non-vulnerable becomes vulnerable, vulnerable becomes non-vulnerable. How can I not have a plaque first of all? And if I have a plaque, how can I see that it doesn't get the non-vulnerable status? And how can I see it doesn't rupture and then produce this? This is all prevention of coronary artery disease. In some people, what will happen is, so here people when they are here, there will be on demand, there will be supply will be less and they experience the angina. And in some people, what will happen is the plaque rupture occurs very wide and a major plaque disruption and a sudden occlusive thrombus occurs without there being a stage of angina or the NSTMI. And directly they can have QV myocardial infarction or the ST segment elevation myocardial infarction or they end in sudden death. I told you 70% will go in the, 30% only will go in this route and 70% in India go in this route. All the more the reason that we should see that plaque buildup doesn't occur, and if it is there, even that is not vulnerable plaque. So this is the basic understanding. Let's go further. So acute coronary syndrome can be broadly classified into two groups. One, where it is not transmural and so ST segment is not elevated. The other is complete transmural occlusion and transmural loss of blood supply and infarction, which is called the ST segment elevation. Okay, non-ST segment elevation, we learned that it is not transmural, it is only subendocardial. Okay, ST segment elevation is transmural. It is it totally the blood supply to one part of the myocardium throughout the thickness of the myocardium is cut off, and that results in ST elevation. We also learned that ST elevation can be due to sudden vasospasm, as in case of Prizmetal angina, where the ST elevation returns to normal. So this non-ST segment elevation has got two components. One component is transient, the other is persistent. If it is transient, it is called unstable angina. And the patient becomes normal, the chest pain recedes, the ECG becomes normal, and the ST segment returns to normal. And this is unstable angina. But nonetheless, he is a future candidate to move in this direction or to go to this direction. So unstable angina is a warning sign where we need to pick it up and then start evaluating and offer appropriate preventive and curative treatment. So what happens in some people, the loss of blood supply or decrease in the blood supply is not complete obstruction of the blood vessel, but partial only, but it is prolonged by more than 1 hour, 2 hours, 1 day. Then there is non-ST segment elevation, myocardial infarction or subendocardial injury and ischemia are there, and that injury leads to a release of the enzymes there, whereas here there is no injury, only ischemia, and then you may have no enzymes elevated here. So that's how they differ. So this can progress sometimes to QV myocardial infarction or non-QV myocardial infarction. Both are possible in the evolution. And of course, ST segment myocardial infarction, ST segment elevation MI is mostly transmural. So there is a QV myocardial infarction. And some areas it could be non-QV also. The classification like non-QV, QV, these are older types of classifications. Today what we say, is it NSTMI or is it STMI? If it is an NSTMI, is it injury alone, ischemia alone, or injury also associated? How do I know? Looking at the enzymes. What enzyme? TROP-I, TROP-T, LDH, CPK, SGPT, all the cardiac enzymes. If the enzymes are elevated, there is an evidence of injury. That means there is NSTMI with chances of progression to the QV myocardial infarction. Suppose the enzymes are not elevated, it is a relatively short duration of time, the ECG becomes normal. That is what is called the unstable angina. Okay. What are the three entities? Basically, no ST elevation or ST elevation. What is the fate line like? Is the fate line shows depression or baseline, or is it elevated? No ST elevation means ST depression is the feature. No ST elevation with only T changes also can occur. That is more with unstable angina. But in NSTMI, there will be depression of the ST segment. The other group is people who have ST elevation, who have a typical transmural infarct. So let's go further. These are coronary angioscopies. What are they? The endoscope is introduced into the coronary blood vessel and the ultrasound pictures are recorded. This is intravascular ultrasound pictures. You see picture here is buildup of the plaque in the subendothelial region. Okay, all the LDL rich chemokines and all the cells or junk food or kurkure, karkare, all non-veg, everything is here. That is the A picture. B is there is a mild plaque rupture in the plaque, but there is no occlusive thrombus or partial thrombus of the blood vessel. That is B. C, there is a significant rupture and there is a thrombus formation here. This is all the thrombus and this is the lumen. Still, patency is there and this leads to NSTEMI. Whereas what happens in a massive rupture, the thrombus forms and the thrombus itself occludes the whole blood vessel, which results in ST segment elevation myocardial infarction. These are the 4 different stages of disease and they will occur in different course of the disease also. Okay. Now, stable plaque, no vulnerability, there is no total occlusion, there is a sort of relative narrowing compared to the normal blood vessel, and they may have stable angina when they exert, when the demand is thrown more, or when they sort of have anxiety, and that is a stable angina. It's very good, a warning sign. And then from there, we have to pick up those people. Just don't prescribe nitroglycerin and leave them. Evaluate them and see whether they will be candidates for future disease. Okay, future serious disease. Okay, then comes the question of vulnerable plaque. Vulnerable plaque is still stable angina only, but plaque has not yet ruptured, which is our picture A in the previous slide. Okay, so this is our picture A. In the previous slide, that is there is a plaque is there and a vulnerable plaque, and there is a minor plaque disruption which results in unstable angina, as you see in the picture B. This is the unstable angina. These are intravascular ultrasounds. And see, major plaque rupture, unstable angina has progressed on to non-ST segment elevation, which is this picture where there is no total occlusion. Still the lumen is there, but the thrombus is occupying a significant part of the artery. And of course the D, where the occlusive thrombus is completely, non-occlusive thrombus has become an occlusive thrombus, and that results in STEMI and death. So the second one is C, and third one is still a non-occlusive thrombus, and this can, because some amount of this one is there, but very quickly this can progress on total occlusion, which can lead to STEMI or sudden death. So what are we interested? We are not interested to see people in this category, neither in this category. We would like to pick them up in this category or in this category and see that they do not progress on to NSTMI or STMI or sudden death. That is the emphasis. Learning ECG and all that is only for that, not to just to classify and learn and keep quiet. So what exactly is happening? So this is called the plaque there. You can see the plaque fissure or rupture, vulnerable plaque. The cap is open, and then the first thing that occurs is platelet adhesion. That is why you use antiplatelet agents immediately to see that the platelets do not adhere. Okay, if they adhere, then no problem. But what they will add when they adhere to the ruptured plaque area, then they get activated. So the activation means the platelet starts releasing all the chemokines and cytokines packed inside them and starts calling all the cells for help. That is activation. So fissure rupture, plaque fissure or plaque rupture or platelet adhesion, platelet activation, and then they will call in more platelets, and that is called the platelet aggregation. All of these, they will have a meeting. The ones which have come earlier and later with all the chemokines, then they will say what to do. There is the plaque has ruptured. Then it will, no, we can't hold this. This is quite a significant rupture, and let us call all our friends, our RBC, WBC, everybody along with all the clotting factors, and let a clot form there. And then so much so the plaque rupture is arrested. Okay, plaque rupture is arrested, but blood flow is also arrested. That results in thrombotic occlusion. Okay, the steps are rupture of, there is a plaque buildup first of all, and that plaque becomes vulnerable. Vulnerable plaque becomes ruptured. Ruptured plaque attracts platelets, platelet adhesion, and then they get activated. Activated platelets release mediators which call more platelets and also the other cells. That leads to platelet aggregation and cellular accumulation, and also triggers the thrombotic event within the coronary, and that leads to thrombotic occlusion. So now you remember how important are antiplatelet drugs, because fundamentally antiplatelet drugs will stop platelet adhesion and then stop platelet activation, they stop platelet aggregation, and they ultimately prevent the end result of thrombosis. Your thrombolytics are drugs which you use to dissolve what is already formed, isn't it? So antithrombotics are your heparin and all that. Okay, this has occurred, but let it not progress to this side. So give heparin and other antithrombotics or anticoagulants to see that this doesn't progress here. Once it has progressed, you use thrombolytics like your streptokinase, urokinase, or all the newer agents to dissolve this clot, or you use a procedure to clear the occlusion. So antiplatelets and up to here, and here anticoagulants, here thrombolytics and procedure. Now you see, quiescent plaque, lipid core is there in the center, the plaque has built up, there is some narrowing, only during demand the narrowing is felt, that is angina plaque formation. It is understood by looking at the blood in the form of NHDL. What is the level of the non-HDL cholesterol? You know, HDL is protective, anything non-HDL is harmful. What is the buildup of the bad molecules or the thieves in the cholesterol? These are the typical thieves. Terrorists, how many are there? These are the associated thieves, and this is also LPA also is a dangerous thief. So it is to measure the number of molecules which are which are pro-atherogenic and not conducive for good health. And this tells you about the plaque formation. If a patient has these in larger numbers, we can imagine, and by anumana pramana, that is by inference, you can say that there is a plaque. That is why we start treating dyslipidemia. Okay. Then vulnerable plaque. How do I know? The plaque rupture is about to occur. The plaque rupture triggers inflammation, calls on macrophages, calls on metalloproteases, and increases the collagen concentration there, and platelet activation, and clotting cascade is triggered, all that. So this is vascular inflammation. Multiple factors, maybe infections also. And how do I know that the vessels are inflamed? By looking at C-reactive protein, adhesion molecules, CCAM, ICAM, interleukin 6, tumor necrosis factor alpha, SCD40 ligand. Today, we can say whether the patient is in this stage, or whether the patient is in this stage, or whether the plaque has actually ruptured. That is because then macrophages are called in, metalloproteases are called in, and then we can see melanodialdehyde modified LDL. There is a molecule called a modified LDL, which is a melanodialdehyde LDL. The moment you see this, we know that the rupture has occurred, and with the blood chemicals, the LDL inside is converted into melanodialdehyde modified LDL. This tells that there is a plaque rupture. Today, pinpointedly, you can say the pathogenesis by looking at the marker. And of course, when you have thrombosis, platelet activation, and thrombin generation, and complete occlusion, you see D-dimers, the complement, the fibrinogen, the troponin, the CRP, and CDL40, all are elevated. So today, I can know whether there is plaque formation, whether it is inflamed plaque, whether it is ruptured, whether there is thrombosis, by looking at some of the markers. Okay. Now, the plaque disruption or fissure erosion or thrombus formation will lead to small little clot, and this is all the plug there. There's a little plug there, platelet plug, and then not much of occlusion of the coronary artery as such, and that is called the unstable angina in olden terminology. Suppose there is a partial occlusion and the transmural infarction, subendocardial infarction occurs, still blood is flowing, that is called non-QV myocardial infarction. When there is a total occlusion due to plaque rupture, it is QV myocardial infarction. These are not used very much now. Now what do you do now? We call them as, these are non-ST segment elevation, acute coronary syndrome. This is ST segment elevation coronary syndrome. In that, there are again two things. Is it transient? Is it coming back, ST segment from the depression to normal level? Then it is transient ischemia. Or only T wave inversion, no ST segment is baseline, still transient ischemia may progress on to transient ischemia is converted into a prolonged ischemia, not transient ischemia. Here we have to write here prolonged ischemia and prolonged ischemia. Okay, I'll again share it. Okay, the prolonged ischemia with injury of the myocardium, and that this is only ischemia here, and there is injury added here. You have ST segment depression, very classically seen, will not return to normal, enzymes are elevated. Here, there is ST segment elevation, acute coronary syndrome, where this completely transmural, enzymes of course are elevated. And here, in this particular, why to differentiate between this and this? Because the treatment differs between this and this. For that reason, I need to know whether it is the NSTMI or STMI. If it is NSTMI, is it transient or is it prolonged? So this is what we need to understand. So let's go further. So what is the treatment? Stable angina, unstable angina, that is transient ischemia, and then injury with ischemia, prolonged NSTMI, and injury, ischemia, and infarction. Also, all three are added there. Infarction added because of the transmural nature. That is STMI. Drugs, A stands for aspirin, B for beta blocker. Here you give A plus B. No need to give heparin because there is no plaque rupture here at all. So there is no need to prevent any thrombosis. Only to prevent the platelet mischief only you treat and reduce the heart rate and give the myocardium a benefit of less workload against that. So they are platelet agent and beta blocker. Here, no heparin, no ICU care, no thrombolysis, no primary PTCA. But these have to be evaluated by treadmill or an angiography, see whether they will develop into these things, and then you can do an elective angioplasty if necessary, or you can offer them medical management depending upon the angio report, but no primary PTCA. You clearly understand. Stable angina is a warning sign to evaluate. No heparin, no ICU care, no lysis, no primary PTCA. Evaluate and decide optimal medical management or a procedure. This is a good patient, is in a happy situation because we know that he has some problem and will be able to tackle. So you give A plus B. When you come to unstable angina, you give A plus B plus C. Because the moment you see unstable angina, that means an ST segment depression is there, the double drug has to be given. Aspirin as well as clopidogrel. How much? 325 milligrams of soluble aspirin, 300 milligrams of clopidogrel, along with beta blocker. Has to be given. You have to give low molecular heparin or conventional heparin, 5,000 units, LMW 0.3 or 0.2 pre-filled syringes are there, you give that. Why? Because this fellow has got a rupture of the plaque and he can go on to thrombus, and we want to prevent the thrombus. That's why we give that. But he should be admitted or not? Depends whether if he is progressing this way, he requires continuation. If he is just unstable angina and the ECG returns to normal, enzymes are not elevated, he need not get into ICU. Of course, no lysis, of course, no primary PTCA, but all the same, these must be evaluated and see whether that they don't progress into this and offer them optimum medical management, or a procedure, either a plastic or a bypass surgery, depending on the angio report. Now, we have a patient who has got ST segment depression, enzymes are elevated, ischemia is continuing, injury is also already occurred, we have seen trop elevated, and we have to admit that fellow. We give A plus C plus G. What is G? The third antiplatelet agent, which is G2B3A inhibitor, epsiximab, eptifibatide. These are the drugs which you add along with the beta blocker. Okay, and then of course you give low molecular heparin here. Conventional heparin is not recommended here because these may go for a procedure. In that case, better to give low molecular heparin. ICU care, certainly yes, because these will progress on to this one. These may progress on to that. So put them in the ICU. We should not lyse them. Underline the word should not, because studies have shown lysis of NSTMI has increased mortality compared to no lysis. And primary PTC also is not done, and is only observed the moment it becomes STMI, of course, offer the primary PTC. Here, what is it? Same drugs here, same ICU care, lysis. If there is no facility for angiography and then the intervention, you can give thrombolytics there and there itself in the health center level itself. Like, your streptokinase or urokinase and all the modern agents you can give, which are injectables also, no need of a drip also. You can save the time and then save the muscle and then refer him to a center where the PTCA and then angioplasty facilities are available. There they can do an angio and decide for a sort of secondary PTCA after the lysis, or directly if he is in the center, he can be given primary PTCA. So it is as important as this differentiating the patient with chest pain coming into my OPD. I require to know, is it stable angina? Is it unstable angina? Is it NSTMI? Is it STMI? How do I know this patient? This patient will have a transient chest pain relieved by nitroglycerin or rest. There are no persistent ECG changes. They may have some risk factors and I evaluate. Give A plus B here. Unstable angina, you also give clopidogrel 300 milligrams and 325. What is the first thing you do when there is chest pain and you suspect not stable angina, but it could be unstable angina? Not taking ECG. ECG taking is later. First of all, any chest pain patient must go on to aspirin 325 milligrams with the hope at least he is here. If he is going to go here, then I add the other two drugs. B plus C also I add, and then depending on the ECG changes, whether it is reversible within a few minutes or an hour or so, or it is continuing, I decide here. If the ischemia injury is continuing, injury is evidenced by the troponin, I go in this direction. No lysis, please. Whereas when there is clear evidence of ST segment elevation occurs at least in two contiguous or related leads, that suggests acute infarction. There must be ICU care. Lysis should be attempted if no primary PTCA is available. In centers where facility is available, straight cath lab, decide whether to do a procedure or no procedure. And depending on that, we have to treat. This is very clinically relevant therapeutic table, which will decide what is the fate of the patient and how he goes into treatment. That is why we need to know the difference in the ECG. So what are the new markers? Plaque formation, LDLC, LPA, homocysteine, stable plaque. Markers of inflammation, vulnerable plaque, HSCRP, adhesion molecules, interleukin 6, tumor necrosis factor alpha, serum amyloid alpha, and then serum CD40 ligand. These are the markers of vulnerability or inflammation of the plaque. Markers of plaque rupture, malonodialdehyde, modified LDL and oxidized LDL, matrix metalloproteases, soluble intracellular adhesion molecules are markers of plaque rupture. Markers of thrombosis, D-dimer, complement, neopterin, fibrinogen levels, and then troponins, particularly troponin, CRP, and then CD4 ligand are the markers of thrombosis. So we tell the patient to walk the dog. This is what people are doing nowadays. They buy a dog, they also buy a treadmill and tie the dog to the treadmill. Huh? And they put on the treadmill and then dog does the exercise and it becomes thinner and very fit. This man or woman, for that matter, anybody, is happily, comfortably in a good sofa. Opposite the idiot box is there. There is beautiful drink in one hand and lot of kurkure, karkare and other munching stuff. Because during TV we have to eat, no. During cinema also we must eat. Otherwise it is not cinema. So during TV watching also we have to eat something. What we eat? Chips. What does it contain? Saturated fat. So all that we eat, and this man after some time will not be even fit enough to occupy that sofa, and we have to entire big sofa of the whole room we have to bring. But dog becomes very thin and slim. This is how we walk the dog. So what this is to say what? All the above story in the previous slides is just man-made. The man who is a ape, 2.5 million years, walking with all the four limbs, then slowly become Homo erectus. Homo erectus has become Homo sapiens and started hunter-gatherer, getting food once in a week or once in 10 days. No 3-day meals, non-veg food and all chips, kurkure, karkare and all stuff on the plate and a lot of hunting and exercise. That man became a civilized man, understood what he should eat, what he should not eat, kept his health, no tummy, beautiful fit man. But now in the last 50 years, our man has come, our Pepsi man, our Coca-Cola man, our McDonald man, our Burger King man, our junk food man has come. The idiot box also has come. It has not only come into the drawing room, there is a TV in the bedroom, there is a TV in the study room. If possible, there is a TV in the toilet also, because I don't want to miss important things happening when I am using the toilet. And this sort of reclining posture also is available. And there is a disposable drinks also are there. You can keep that goes on drinking, thinking about only these things and nothing else. What happened? An evolution of 2.5 million years is just crashed to dust in 50 years. Within no time, a beautiful, healthy, mind-wise also this man is very healthy. He is not thinking unnecessary things. Here he has got all sorts of vested interests and then kama, krodha, lobha, moha, mada, matsari, everything is in his brain. And all sorts of pulled in all directions with all the five senses. And he is going to perish unless you cut down this and then make the man again healthy. All the story we are looking at is only to see that the further worsening doesn't occur and if possible some redemption can be done to previous health. Now, acute myocardial infarction is not a song, right? Acute myocardial, if somebody says I got acute somebody patient has got acute myocardial infarction, it is not something to celebrate unless his son is waiting for the death of the father. Okay, now it can throw in several complications. The best way to understand the complications is this slide. I couldn't find a better way of representing all the complications of acute myocardial infarction in one go. Look here, acute myocardial infarction can go on to expansion of the infarct. So infarct, when you see initially 2 leads, it becomes 3 leads, 4 leads, it becomes anterior lateral, or lateral inferior and posterior inferior, goes on extending into the other areas. And there could be little bulge or the aneurysm. First thing is extension, massive extension here, and the ischemia may be there in the remaining zones, and the remaining part of the myocardium also may be jeopardized and may lead to death. Or it could extend as well as aneurysm formation. Or the infarct area may rupture and produce cardiac, septal rupture or myocardium, AV valve rupture or MV rupture, mitral valve rupture, chordae tendineae rupture, all these things, mechanical complications. Or this infarct is notorious to produce wrong electrical signals that can trigger a dangerous arrhythmia like VTAC and ventricular tachycardia and sudden cardiac arrest and asystole. Minor and major arrhythmias can occur. Or this can also inflame the pericardium around and produce post-myocardial pericarditis, Dressler syndrome, or during the myocarditis also, during the myocardial infarction also, pericarditis. Or it can extend into the right ventricle also and produce an RV infarct. Or the infarcted area is a nidus for thrombus formation, mural thrombus. This mural thrombus in the left ventricle can get dislodged into the systemic circulation and produce thromboembolic complications. Or the myocardial contractility is so reduced that the effective output is not there. Blood stagnates in various circuits. Stagnation in the pulmonary circuit is heart failure. Stagnation in the systemic circuit is right heart failure. Left heart failure, right heart failure. Have you ever seen a slide of this nature which tells you all the complications? Extension, aneurysm, mechanical rupture, arrhythmias, pericarditis, RV infarct, mural thrombus, heart failure. These are the various things that can occur. So much so, we need to understand acute myocardial infarction, take it seriously and treat him and see that he doesn't get into any one of these things. It of course depends on the various presentations and also the underlying comorbidities that are necessary. So immediately the comorbidities must be looked. Any patient who is admitted with myocardial infarction, the first question I ask, what is the fate line? And on the phone, second question, is he a diabetic? Because the prognosis in diabetes is much poorer compared to non-diabetics. Hypertension, dyslipidemia, obesity, microalbuminuria itself is an independent marker. Male gender, is he a smoker, a sedentary lifestyle, couch potatoes. Couch potatoes are people who sit on the couch and then have the TV and goes on munching the potato chips. So food kapram bed. If possible, food on the bed. And before that, there is a TV. That is the story here. Again, family history of premature coronary artery disease means what? First degree relative, less than 50 years in men, less than 60 years in women. So first degree blood relative is having coronary artery disease, which is family history of premature CAD. Presence of LVH by echo or ECG is a single important prognostic factor. LVH by itself is an important prognostic factor. Emerging new risk factors like LPA, homocysteine, markers, HSCRP, all those things. So you have to evaluate those. Now, prevention is the only answer. The doctor is just giving him a very clear idea. What fits your busy schedule better, my dear? Exercising 1 hour a day or being dead 24 hours a day. What will happen? If we don't exercise 1 hour a day, who has to exercise? Not me and my co-faculty. From your age, you have to invest for future. When do you save? You start saving right now. This is your insurance. And without exercise of 1 hour a day, later years are going to be really, really painful. Then we have to spend on the bed as though we are dead throughout the day. Okay. Hippocrates said, not now, from 2000 years ago, let your food be your medicine. Let your food be your medicine. And just as you take medicine in small quantities and also very selected quantities, selected foods, lest your medicines will replace your food. Then we have to have a breakfast, a full plate of tablets as breakfast, another full plate of tablets in the lunch, another full or double plate of tablets in the night, and all procedures, injections, veins, frequent tests, everything. Let your food be your medicine, lest your medicines will replace your food. Okay. This is just as said in scriptures. Kshudyadhisya chikitsyatam. Kshudyadhi, that is your hunger. You treat it as though you treat with medicine. The food should be medicine. Okay. Now let us come to the story proper. The story proper here is this ECG. What is this ECG? Some of you can already read it. So those who have you have seen already certain things. First of all, tell me what is the rate of the ECG. Let us see what is the rate. Okay, this is the darker line. 300, 150, 100, 75, 60. Somewhere between 75 and 60, maybe around 67, 70 is the heart rate. So first answer is there is normal heart rate. Is it sinus rhythm? Yes, there is a P wave, QRS, there is a P wave, there is QRS, there is a P wave, there is a QRS, everywhere it is like P wave. QRS also are narrow, so it looks like a sinus rhythm. Sinus rhythm, rate 70. Okay. What is the axis? This is up, this is down. What is that axis? Left lead. Patient is having left axis. Okay. What is the dominant deflection? L1. L1 lead is this side. AVL lead also this side. So the dominant deflection is towards the left. So left axis is confirmed. What is there any atrial disease? I don't see because I have to see here and here. And here the P waves are normal. Here also there are no P wave changes. So there is no atrial enlargement either right or left. Okay. Is there any bundle branch block? Before that, is there any heart block? My PR intervals are constant. I don't see a change in the PR intervals. Neither I see any dropped beats, but I cannot comment because I am only given 3 complexes. For commenting on the conduction, we require an L2 long strip. At least 20 beats should be available. Okay, let's assume there is no first degree or second degree or third degree heart block. Certainly third degree not there because there is no ventricular complexes here. And then what is next is there? Is there any bundle branch block? There is bundle branch block, right bundle branch block, I see. RSR pattern and an M pattern here, I don't see that. Left bundle branch block, I see M pattern here and a sort of slurred R wave here, S wave here, that also is not seen. So there is no bundle branch block. So this, up to that we have learned. And there is no conduction defect. Now the question is, what is my baseline, fate line? What is my fate line here? What is the fate line in the ECG? Its baseline is normal only almost, not much of depressed. We want to say depressed, at least 2 millimeters it should go. But contiguous leads it is there. So possibility that there is an ischemia is definitely there. Injury is also possible, but there is no ST elevation as such. Here also we see T inversions in lead 1, V4, V5. V4, V5 lead 1 LVL tells me it is lateral, and V4 and V3 tell me it is anterior. So it is anterolateral, anterolateral. This is also lateral. So there is something going on in relation to ischemia or injury in the lateral leads. Now question is it unstable angina or is it NSTEMI? How do I know? I have to wait. Repeat the ECG after an hour. And then what should I should give? I already told you. I have to give him A, I have to give him B, I also should give him C, and also give him heparinize the patient. And then if the ECG returns to normal within an hour or so and the pain regresses and the enzymes are negative, he is not having NSTEMI, but he had only unstable angina. Okay. So this is the age of the patient and gender also is given and the race also is given, Hispanic. This Yanovich, Frank Yanovich is the student of our great teacher of ECG, Helen Lindsay. He is the one who started the website and some of the ECGs are from them. Okay, this is how you go about. First of all, rhythm, rate, axis, P wave for atrial enlargement and ventricular enlargement, conduction defects, then the hypertrophies, then ischemia. Look at the baseline, look at the T waves, look at the ST segments. This suggests definitely there is some ischemia injury complex going on in the anterolateral. My question is it ischemia alone or is there injury? If there is injury, I require to admit him in ICU. Okay, if there is no injury, I can send him home and evaluate him as an elective patient. How do I decide? Give him treatment. And what is the treatment I have to give? First thing you see any patient coming with chest pain, you give nitroglycerin. It doesn't work. It doesn't work. Why? In only a stable angina it works. When there is some unstable angina or a clot is going to form, what is this nitroglycerin going to do for you? In fact, it may be detrimental. It will bring down the blood pressure and the perfusion pressure will fall. Don't give nitroglycerin straight away. Sublingual nitroglycerin is not the answer. Sublingual isosorbitrate is not the answer. Please wipe it away from your mind. Later on, you can give, if the ischemia is persisting, pain is there, you give. The first drug is 325 milligrams of soluble aspirin. I don't have soluble aspirin, sir. What should I do? Crush the entry-coated aspirin. 2 tablets, powder them and drink it. Ask him to drink. Keep solaspirin. Every patient of ischemic heart disease, every practitioner must have soluble aspirin. And this soluble aspirin is 325 milligrams. It's available. Put it in 1 tumbler of water, dissolve and then drink it. Or drink it, take the tablet and drink 1 glass of water. Both are same. That is the first thing even before the ECG is done. The second thing is, if the heart rate is 90 or 100 or more, give beta blocker unless there is an absolute contraindication. Like frank heart failure or severe bradycardia, beta blocker is not given, but in general, they are well tolerated. Give cardioselective beta blocker, metoprolol, 25 milligrams straight away. Not the extended release, the immediate release beta blocker. Metoprolol XL will be there. Don't use XL. This is not XL here. While discharge, you can give. At the time, you give immediate acting beta blocker. Okay. And then third drug A and B given. Then I have to give C because I am suspecting ischemia injury. In 4 leads, it is there in this particular patient. I have to give him clopidogrel. How much I give? Loading dose 4 tablets of 75 milligrams or 300 milligram also is available. Give 300 milligrams straight away. That is the fundamental basic thing we expect from any practitioner who sees a patient like this. On top of that, if the facilities are available, admit him and observe him. If the ECG is returning to normal in 1 hour and the symptoms are regressing, enzymes can be done. Point of care enzyme is available now. I take 2 ml of blood and put 1 ml in that small well-like thing. I see 2 lines, drop positive, 1 line, drop negative. As simple as that. It's very easy. In 15 minutes, you can decide whether you can keep the patient or you have to refer. Suppose the drop is negative. Okay. So far so good. Drop negative. There is no active thrombus going on there. And most likely it is NSTMI, but still not sure. What I will do? Repeat the drop after 6 to 8 hours. If the ECG is continuing to be normal and the second drop also is negative, you are safe in discharging him with the prescription A plus B plus C and ask him to come for elective evaluation. Okay, but if the drop is positive, is the first or the second, or the symptoms are not regressing, or the ECG is not coming back to normal, or there is an extension into the other leads, we are in for trouble. And the patient is in the ICU and he has to be monitored. He may go in for ST elevation myocardial infarction and may require immediate angioplasty or angiography and angioplasty. So try and shift him to a cardiac care hospital where angiography is available. So this is this patient. What happened? Let us assume that after 1 hour, the ECG has become normal, the pain has regressed, his drop is negative, we call him an unstable angina. Okay. Now, presence of 1 or more of the 3 features, crescendo angina, more severe, prolonged, frequent, decrease in the exercise capacity, new onset brought on by minimal exertion, not relieved by nitrates, angina at rest as well as with the minimal exertion. These are the 3 classes, 1 to 3. This may progress on to NSTMI and STMI. After giving these drugs, if you still feel if the blood pressure is normal, give nitroglycerin. Nobody is going to find fault, but that is not the first one. Now look at this ECG. Make up your mind. I'm not going to ask you rate, rhythms, all the things in this because I don't have a full ECG. I only have a few leads only I have. So I can't tell anything more about the ECG other than what is given to me here. What do you see here? Very prominent ST elevations of as much as 10 to 12 millimeters. And I told you earlier, the ST segment elevation is the degree of elevation or the number of millimeters. It's directly proportional to the extent of myocardial damage, which is directly proportional to death and fatal outcomes. So if a patient comes with 2 millimeters ST elevation, another patient with 10 millimeters ST elevation, the fellow with 10 millimeters ST elevation is a poor candidate for good prognosis. You will not get a good prognosis. Now what do you see? Severe ST elevation. We thought definitely it must be myocardial infarction but the patient, I did a drop on this patient, drop is negative. With this ST elevation, the heart must be crying and the enzymes must be very elevated. So it's not. CPK is normal, LDH is normal. Then in half an hour, the ST segments return to the baseline and the patient's symptoms of chest pain has vanished. What is that? This looks like acute myocardial infarction, acute ST elevation Q wave myocardial infarction, transmural myocardial infarction. Patient recovered within 1 hour. ECG returned to normal. Drop is negative. This is what is called vasospastic angina. Vasospastic angina, also called the Prizmetal angina. What is the treatment here? Beta blockers are contraindicated. Calcium channel blockers are the treatment of choice. Okay, you have to give CCB and not a beta blocker. Why? Read. Prizmetal angina, you read, you understand that. I'm going to leave certain things for your looking up. Now, look at this ECG. We looked at it. It is Prizmetal angina. How do I know? From the one ECG, I cannot tell. One ECG shows there is myocardial infarction. Like picture, ST elevation myocardial infarction. Immediately ask for drop test, and drop is negative, I told you, and observe him for an hour or so. ECG returns to normal. Transient ST elevation during chest pain due to coronary vasospasm, also called variant angina, ECG with severe ST elevation becomes normal soon. There are no Q waves. So you don't see any Q waves are everywhere. The R wave is seen here. The R wave is seen, and this is S wave, and here also no Q wave. So there's no Q wave in any one of the leads. And also the ST segment elevation has come back to normal. Often repetitive, usually at rest. This angina is not related to effort because it is not supply problem. It is more a demand, it is not a demand problem, but more a supply problem. Demand problem is if I walk, if I exercise, demand is more and the ECG changes occur in classical angina. Whereas here the spasm is a supply problem. So it is usually at rest early in the morning. Other vasospasms, symptoms may be there like syncope, Raynaud's phenomena, migraine, other vasospastic disorders may be coexisting. Beta blockers are contraindicated. Calcium channel blockers and alpha blockers are the treatment of choice. So what did you learn till now today? You learned the pathogenesis of acute coronary syndromes. You know what are the various markers that are available to find out the disease in various stages. You also knew that the prevention is the key, and you also had a basic structure of treatment depending on the presentation and where the patient goes into that. We also knew that the myocardial acute coronary syndrome presents with two groups, NSTMI and STMI. NSTMI has got two components, the transient component, unstable angina, the persistent component, which has got injury built into that, which is called the NSTM elevation myocardial infarction. And here, and finally, we have the third entity, which is called the ST segmented elevation transmural myocardial infarction. Why I need to distinguish them? Because my treatment is different. How I need to distinguish them? Look at the first of all, The patient comes with chest pain. No, not ECG is not the first thing. 325 milligrams of aspirin. What if it is not cardiac pain? Nothing happens. What will happen? If you give 325 milligrams of aspirin, even to an acute gastritis patient, nothing is going to happen. You are going to give only one particular tablet. So it saves. An aspirin given early has saved more lives than PTCA. There are studies to document patients who have aspirin early in the disease are more protected than those who went in for angiography. That doesn't mean angiography is useless. We have to give everybody with chest pain, particularly in the vulnerable age. You can see the age and structure of the patient, not a 2-year-old fellow coming with chest pain. So you have to decide to give aspirin, and then if there are no other contraindications, straight case beta blocker also. Then look at the ECG. ECG is an STMI, STMI. If an STMI, what is my drop? Drop normal, ECG negative, and then observe after 6 hours, again repeat drop, still negative, unstable angina. No lysis, no ICU, no primary PTCA, but elective evaluation. Whereas persistent chest pain is there, ECG abnormality is continuing, drop is positive, he is to be in the ICU. And then no lysis, please, because non-ST segment we should not lyse. And then he is a candidate for secondary or elective angioplasty. And then the other group of patients who presented with acute chest pain, typical of this one, A plus B plus C is given, heparin also is given. We took an ECG. ECG is very high elevated ST segments are there. And only thing is it vasospastic angina? I know in a moment's time, in about half an hour, 1 hour, the pain recedes in the ST segments return to normal without much of a procedure. That means it is vasospastic angina. At that time point, if the ST segments are still elevated, I continue to admit him. In a center where no facility is available for angioplasty, you do only lysis, chemical lysis. If the center has got facility, you do a primary PTCA, or you do a sort of bypass surgery. Afterwards, once the acuteness is tied over, the culprit vessel has to be first opened up. So this is the story, and we looked at 2 ECGs, one of Prizmetal angina, the other of unstable angina. And then, what is this ECG? Maybe we'll stop with this ECG. Here you see, which leads are affected? L2, L3, AVF. These are the inferior cameras. Okay? And also little bit in L1, not much in AVL, and then a little bit on the lateral. So probably inferolateral, not much in the anterior. Anterior appears normal, septal appears normal. Inferolateral wall has got the depression of the ST segments, and there is T waves are not yet inverted. Usually in NSTMI, what will happen is the ST segment depression will be there, T waves are upright. Whereas if you see the previous ECG, you see here, there is a suggestion of ST depression, but more of T inversion in unstable angina. Whereas that is injury, that is ischemia, whereas this is injury. So the injury part here, now we do a drop will be positive, and he must be treated vigorously in ICU and expect him to become complete through and through infarction. And you can now say the rate. What is the rate like here? 300, 150, 140. There is tachycardia also because of the underlying infarct. What is the axis like? Normal axis. Looks like sinus rhythm, P waves and QRS normal, no QRS widening, no right bundle, no left bundle, and the axis is normal. And there is tachycardia with suggestion of inferior lateral injury. That is because of the NSTMI confirmed by the drop. ECG continues to be like this. So this is a case of non-ST segment elevation infarction, whereas non-STMI or NSTMI, non-QMI, also called subendocardial because it is not through and through, non-transmural, restricted to the subendocardial region. There will be no ST elevation here. ST depressions in the anterior lateral and inferior leads, as we have seen, prolonged chest pain, autonomic symptoms like nausea, vomiting, and sweating, persistent ST segment depression, even after resolution of the chest pain. You have given some treatment, chest pain is suppressed, and you gave him some pethidine also, so chest pain became better, but the ECG continues to be there, CPK starts increasing, LDH starts increasing, and trop is positive, patient is NSTMI. So we will wait for these ECGs. Next time we will see, maybe at this point, I will stop. I have shown you 3 ECGs, one of unstable angina, one of NSTMI, one of Prizmetal. I'll show you the other ECGs. I thought of going up to 178, but I will slow probably to explain you the pathogenesis. So it's good, doesn't matter, no hurry. So if you have any questions, you can ask me now, and I will stop sharing.